Do we have questions from the audience? Yes, please. Microphone for the gentleman over there, please.
I have a question for the radiologist speaker who spoke about dry needling. I am completely unaware of this technique. Can he elaborate a little more about dry needling and how does it work?
Yes, it is an image-guided treatment actually, which is not only for partial tears of the rotator cuff. I'm also using these in tendinopathies, plantar aponeurosis, and lateral epicondylitis and medial epicondylitis. Actually, I'm just causing trauma into the tendon with some bleeding, and the growth factors from the bleeding regenerate the tendon. This is very efficient, particularly if the patient is not very old, not diabetic, and not a smoker.
But that area is avascular. The distal part of the supraspinatus tendon, 4 centimeter, very close to the attachment, is completely avascular. So unless you
it's
drill,
not totally avascular. Actually, it is the vascularity is reduced. But the dry needling is not only confined to this area of avascularity, it is also in the footprint, in the distal, and the more proximal, and in some cases that the degeneration is extensive. I'm also getting 1 milliliter of its own blood for autologous injection.
Okay, please, Carla. Microphone over here, please.
Sorry, Tom. Can I make a question about this subject?
Yes, sure.
Aren't you afraid of completing the partial tear when you do that?
No, because I'm doing this in small intrasubstance tears, not in large tears, not in the bursal side or the articular side, only intrasubstance. And it never happened, actually. And this dry needling technique also is used for Achilles tendinopathy. It's very efficient.
Hello. I have a question for Dr. Adar. Excuse me? Yes, it's me. Thank you for your presentation. It was very enlightening. I'd like to ask you what you think about this. You explained this very well, that the initial phase of abduction is contracting the scapular stabilizers, right? So what do you think about in irreparable rotator cuff tears when we transfer the latissimus dorsi or the lower trapezius? Do you think that this will affect the restoration of abduction in these patients?
First part of my answer will be, we are working according to motor engrams. So the patient with the massive rotator cuff tear uses old patterns, he will never succeed. If we change the pattern, he may succeed. About the latissimus dorsi transfer, I already said it, if you take the latissimus dorsi and pass it into the head, you remove the strong antagonist of the deltoid. And then you don't have to have a stronger deltoid. You can use what you have, and you have the depression of the head, you have the lower inclination of the scapula by the latissimus dorsi together with the head, and it's the optimal conditions for the irreparable rotator cuff tear.
What about the lower trapezius?
I have no experience with this. I can't see the rationale about it.
I have another question for Dr. Anna. This is related to the natural history of rotator cuff disease. So in those natural history of rotator cuff disease, are there any indicators like critical shoulder angle or the acromihumeral distance, and which indicator is a more important indicator for knowing the natural history of the progression of the rotator cuff disease, if you have to see it radiologically or MRI diagnosis?
So, do you want to know if radiologically if there's any index that predicts the natural history of any rotator cuff?
Yes.
Not that I know of. My message was precisely that it's very specific. There's a lot of different pathways that the rotator cuff can pursue depending on the patient and depending on the tear itself. So I think probably it's not effective to even try and establish an index that covers them all. That won't be possible in my
There is one wonderful study. I'm not saying it is the study, but the wonderful study by Christian Gerber on critical shoulder angle and its relation with the degeneration of progression of rotator cuff tear, and it is wonderfully been depicted. Somehow, I think you missed it in your talk about the critical shoulder angle.
I missed it, maybe on purpose.
Good one.
Any further questions? Looks like our angels in white or green who makes life easy for the orthopedic surgeons are not here. So, are you here? I have a question for Zaira. I have a good friend. He's a former SAS shoulder, and however we push him, he never feels pain. And he says, I have this ability, I can disconnect my brain from my body. I never feel pain. So that's one thing. Another interesting fact is there was an investigation where they looked at the personality of patients before shoulder surgery. Yeah. And they found that the only significant factor they could find was if a patient stated before surgery had a very, very high pain threshold, they were the only patients who had uncontrollable pain afterwards. So I would like you to comment on these two interesting factors, which are probably more in the psychological.
The first one that you said, okay, the first one that you said as a case, I think he's a fan of Descartes, who said that you can have your brain out of your body. Cannot happen. Probably he has some pathology that he has to be examined for. There are, yes, it's true. There are some genes that are related to people that don't feel pain. But these kind of people are implicated in accidents when they are children because they don't feel pain. And they most don't survive until they become ager. So the other thing that you asked me, I have to say that I'm familiar with many, not only one research, and research for shoulder. I've presented it about 2 years ago with many cases, like 300-something cases, with persons that had psychological problems before. And most of them, like say 30% of the percentage, had pain after the surgery too. So psychological factors are very important when we assess pain and when we communicate to a patient that he will be in surgery and after surgery everything will be okay with his pain. We have to have a multimodal approach to pain always because of that. Okay, thank you.
Thank you, thank you. One more question here, yes? A microphone, it's there.
Just a question for Irene. Do you have an experience of interscapular block? Because in France, why?
Because of the problems that were caused sometimes before. We want to send them home. They don't. Greek patients don't really like the fact that they're not able to move their arm. They feel trapped. I don't know. Maybe the psychological reasons that we discussed before. They want to have an arm functional after the surgery. They don't really feel pain. 3 hours after the surgery, they are the opposite of the hospital drinking coffee.
Yes, but the block, in my own
Yes.
experience, when we don't use the block, some patients have more pain during the surgery, so more bleeding, and it's some kind of more difficult to make the surgery.
With just general anesthesia without block?
Yes.
No, we don't. We don't have. We use intravenous anesthesia.
So maybe you have to give me your tricks for my anesthesiologist.
Of course. I'll be very, very glad.
Thank you very much. A big hand to the speakers, and we finalize this session.
Thank you.